So I'm here on time today because I'm doing the introduction. Some of you who were here last year may have remembered that I brought two people here to talk last year about improvement science, and this is sort of my little project to think about where improvement science and informatics intersect and how that might fit into both our projects and our teaching or our coursework, depending on which side you're on. And so last year we had someone from the Improvement Science Initiative and someone from Family Practice who does a lot of work with informatics. So today we're lucky to have Elizabeth Crabtree here. Elizabeth is the Director of Clinical Integration and Evidence-Based Medicine here at OHSU. That's a new position as of almost 2 years ago, just shy of 2 years. And she came here from the Medical University of South Carolina, where she did something similar. And I'm not going to explain what she does because she's going to. And she's also faculty here at DMICE and has been working with us at the EPC on some of our national guidelines and initiatives, as well as with the work she does here for OHSU. So I'm going to turn it over to her.
Great, thank you. Well, thank you so much for having me. As Annette mentioned, I work as the Director of Clinical Integration, Evidence-Based Practice, and then spend a portion of my time in the Pacific Northwest Evidence-Based Practice Center. And I came here from the Medical University of South Carolina. I also spent some time at Texas Children's Hospital. And so for the last 10 years, my primary focus really has been working with interprofessional teams of clinicians to develop and implement guidelines at the health system level and to design systems of care that essentially make it easier for clinicians to do the right thing and integrate research evidence into practice. So as Annette mentioned, I've been here about 2 years. I'm very delighted to be at OHSU because, as many of you know, OHSU is now forming partnerships with community hospitals, so it's been a challenge and really interesting to see how we can do this work, not just within a hospital, but across a health system. And then, of course, having access to the tremendous resources within the Evidence-Based Practice Center makes this work really fun to partner and work with clinicians who essentially author national guidelines and are able to speak to the evidence in such a clear, concise way has made the job really delightful. I've really appreciated being here at OHSU. I don't have any conflicts of interest to disclose. So I realized that this slide might be a little bit unnecessary given that the EPC is right upstairs, but I recently presented on OHSU's supplemental feeding guideline in neonates at a breastfeeding conference in Florida. And I spent 30 minutes talking about our evidence-based guideline, our process for developing and implementing it. And at the end of the talk, someone asked me to define evidence-based practice. So I thought I would just lead with this going forward. But evidence-based practice as a field is relatively new. So the term evidence-based medicine was first coined in 1991. Of course, there's been a lot of work to kind of lay the foundation for it many years prior. But Dave Sackett's considered one of the fathers of evidence-based medicine. He's a Canadian physician, and he defined it as delivering care that's based on the best available evidence mediated by your patient's values and preferences and your clinical expertise and competence. So I think this gets at the fact that not all decisions are going to be based on good evidence, but the expectation is that care should be delivered based on the best available evidence and that we should be really transparent about the evidence supporting it. So I think one common misconception of evidence-based practice is that it is just simply the reflex application of data from randomized controlled trials into patient care. When in fact, I think it's really much more complex than that. So of course, evidence should guide our decision-making, but there are a number of other factors that I think can sharply influence how a given piece of evidence would be applied to a patient in front of you. And that really gets at the point, and I think a fundamental tenet of evidence-based practice is that care cannot be based on evidence alone. There are a number of other things that, as a clinician, you need to be mindful of. Your patient's values and preferences, your competence and your skill as a physician or a clinician for providing a given treatment or intervention. And then, of course, we also want to be mindful of costs issues and resource constraints. And I think it's the ability to look at the evidence and then be mindful of all of these other components, which leads to what, from an evidence-based perspective, is clinical expertise. So I thought this was funny. Physician said, we have two options, either an evidence-based treatment or an exciting, risky alternative. But when I showed this to a friend of mine who's a psychiatrist, who's been practicing for about 30 years, he said, you know, Elizabeth, I don't really think that's funny, because it doesn't at all speak to the dilemma that we as clinicians face. We're not often forced to pick between something that's proven and effective and some sort of obscure, risky alternative. Instead, we're often given two sort of partial, sometimes conflicting sets of information, and we have to figure out what to do. And I thought, you know, that's really what evidence-based practice can provide, is succinctly summarized, clear information that allows the clinician to determine what to do with the patient that they're treating. And I think also highlights the fact that we need to design systems of care that make it easier for clinicians to have access to that information and then also to act on it. So I think there are a number of drivers in our healthcare environment that would indicate we need to, as a system, figure out how to do this more effectively, how to effectively integrate best research evidence at a systematic level. So data from Dartmouth Atlas and the New England Healthcare Institute show that 30% of the nation's healthcare spending is essentially waste. This is largely due to unwanted, irrational variations in care. For the last few decades, payers, both commercial and government, have been trying to reduce this waste, but have not been very successful. And then I think, too, especially for academic health centers, there's sort of the expectation now that we're going to have the capacity and ability to manage the health of a population of patients. And then lastly, I think just the sheer volume of information out there makes it really challenging for any one clinician to evaluate and translate all the existing knowledge and information on their own, much less apply it, which I believe really highlights the need to do this in a more systematic fashion through the conduit of an EHR. So we know that evidence-based practice leads to higher quality care, better outcomes, can lead to reductions in costs, and also greater clinician satisfaction, which is why U.S. News and World Report and Magnet and now required reporting programs are becoming increasingly interested in how clinicians and systems deliver evidence-based care. So the question is, how do we get there? How do we as a health system do this well and effectively? And I'm hopeful that that's something that our department, the Office of Clinical Integration and Evidence-Based Practice, can assist OHSU with. So we essentially exist to support clinicians in providing high-quality evidence-based care. And we do this through sort of three different mechanisms. So the first is we develop evidence-based guidelines at the local health system level, where we allow for clinicians to come together to sit around the table and come to consensus around how care should be delivered for a population of patients. Coming to consensus can be challenging, but putting something on paper really is the easier part. So where we really see the most impact and where there really is the most challenge is when we start talking about implementation. So we provide support for that as well. So for all of the guidelines that are developed, we launch formal implementation teams that are multidisciplinary, and we do things like work on enhancements to EPIC. We do patient and provider education. Sometimes we may see that there's gaps between what best evidence is and what our resources are, so that may lead to proposals for programmatic development and enhancement. So it's really about changing the behavior of clinicians, but also changing the behavior of the health system and how we're delivering care. And then lastly, outcomes evaluation is a really important portion of this work. So our content expert teams that are developing guidelines identify the quality measures that they want to track and monitor, and we work with our friends in reporting to get that information back to the content expert team to figure out how to move forward to drive for improvement. So I feel like we've been really fortunate to assemble a highly competent and effective team, and they're all in the back. We have three program managers, Marcy Hager and Tova Cole. Both are focused on guideline development. and we have a program manager whose focus more is on implementation. We're supported by a medical librarian, and then we have an administrative assistant slash research assistant slash guru of everything, Kristen Camp, who's tremendously helpful to us in our group. And that's kind of the core component of the EBP team within our department. But we rely really heavily on the content experts that serve as guideline panel members to really move this work forward. And then within clinical integration, we also have a number of program managers that are focused more on piloting different clinical models, alternative payment models, things like that. And we also provide support for OHSU's delegation protocol program as well. So when we started doing this work 2 years ago, we realized that there really wasn't a group at OHSU that had oversight over care standardization across the continuum and throughout the enterprise. The Pharmacy and Therapeutics Committee at OHSU is a very engaged, multidisciplinary group that had done a lot of work around protocol development, but their scope was pretty narrow, and it was focused more on pharmaceutical therapy. But they have since revamped themselves. They've expanded membership and their scope, and they've made their name impossibly long. They're now the Clinical Knowledge and Therapeutics Executive Committee. But that's the interdisciplinary governance body at OHSU that's responsible for reviewing and approving protocols and guidelines at the health or at the OHSU site level. And then at the OHSU health system level, so when we talk about partnerships with Quality and Adventus, there's another group. It's the OHSU Health System Clinical Integration Committee, and it's comprised of membership is 2 physician leads from each hospital, as well as the chief nursing officer, and then the CMO from each site also supports the work. And that's the group that's really responsible for targeting guidelines for development, as well as identifying different content expert team members from the various sites to serve on guideline development teams. So I don't really feel like this work would be possible or nearly as meaningful without this governance structure in place to support it. So in terms of how our guidelines are selected, there are a number of factors that we consider. So we look at cost and quality data. We look at local and national trends. So the guideline that we recently developed around opioid prescribing for chronic non-cancer pain, that was largely in response to just the public health crisis that we're seeing across the U.S., but also here in Oregon as well. But we recognize that clinicians really are in the best position to identify what the best opportunities are and where there are gaps in quality. So we solicit input from clinicians. Any clinician throughout the health system can submit a request form for a guideline, and then it gets prioritized. So we've developed a prioritization matrix that the Clinical Integration Committee at the OHSU health system level uses to identify guidelines for development. And we look at things like sponsorship and alignment. So are we going to have clinicians willing to sit at the table from the various hospitals? Does it align with a strategic organizational priority? What's the quality, safety, and patient experience benefit that we anticipate coming out of the effort? Is there a cost savings or cost avoidance component that we could look at? Does this impact a population of patients that OHSU is at financial risk for? So that's another thing that we take into account when we're selecting guidelines for development. What's the impact relative to the effort? Are there best practices that we can draw from? So are there existing national guidelines that we can pull from? Is there an EPC or an ARC report that is available to us, or does this impact a required reporting program? And then lastly, but certainly not least important, we also want to know the impact this is going to have on provider wellness and satisfaction, because the purpose of this work really is to make it easier for doctors, nurses, clinicians to do the right thing. So here's a snapshot of what our guideline development process looks like. So as I mentioned, we use multidisciplinary clinical teams to do this work. Ideally, anyone that would have interaction with a patient, so any discipline or specialty that would touch the patient while they're here in the hospital should have representation on the committee. And we also have a patient or caregiver represented as well. And that content expert team is responsible for defining the scope of the guidelines. So the inclusion, the exclusion criteria, the clinical questions that they want to answer that are going to inform the evidence review. And then the purpose of our group really is to remove the burden of the search and summation of the literature from busy practicing clinicians. So we'll partner with a medical librarian. We'll do an exhaustive search of the literature, both for existing guidelines, and if necessary, we'll look at primary research studies as well. We'll critically appraise and analyze that evidence. We'll summarize it, and then we'll bring it back to our content expert team, who will bring their clinical lens to looking at the data. We also have that patient voice there to make practice recommendations and consensus statements that really drive the development of the guideline. As I mentioned, our content expert teams also identify the quality measures that they want to track and monitor, so that's certainly a part of it as well. And then after we've got the guideline and go through the approval process, we move to implementation. I'll just note that we use the grade. We kind of use a modified version of grade. It's sort of quick and dirty grade because we're on a condensed timeline. So most of our guidelines are developed over the course of about 4 to 9 months. So we aren't always necessarily doing a meta-analysis. Sometimes it's a little bit more of a more qualitative, but we do use grade as a way to assign a level of evidence or a strength of evidence. And so those of you who maybe aren't familiar with grade, it's a really nice tool developed by a group of international guideline developers. A lot of medical societies that are doing guideline development have moved to grade because it allows you to assign an overall quality rating to a group of studies, as opposed to just looking at a single study. And then you'd assign that a quality rating of very low to high, depending on type of studies you have, how closely they relate to your question of interest, and any study design limitations that may be present. But the really neat thing about it then is it allows you to go a step further and actually make a practice recommendation. So you'll make either a strong or a weak practice recommendation. Strong recommendation meaning that the desirable effects clearly outweigh the undesirable effects, or vice versa. You can make a strong recommendation against something. And then a conditional recommendation is where things are a little bit more closely balanced. So it allows you to make a recommendation from a body of literature and be really transparent about the level of evidence associated with it. And as I mentioned, we want to draw from existing high-quality guidelines, but not all guidelines are created equal. There's quite a bit of variability in their quality. So the tool that we use for appraising guidelines came from an EPC at the University of Pennsylvania. It's a mouthful too, but it's their trustworthy guideline rating scale. And it looks at 8 different domains and allows for you to kind of get a sense of how robust the methods were in putting the guideline together. So then once we have an approved guideline, we move to implementation. And as I mentioned, again, there's a separate team that's formed, that's multidisciplinary. And the goal is to figure out how do we design systems of care to make these recommendations easy for clinicians to follow. So whether that be enhancements to EPIC or EHRs across the health system, or whether we need to educate and train both patients and providers, that's all considered as a part of implementation. So we don't want to reinvent the wheel. As I mentioned, one of the great things about being here at OHSU is we have the Pacific Northwest Evidence-Based Practice Center right upstairs. So there's a lot of great material for us to draw from, and we'll start there. But I think what's really valuable about doing this at the local level, because oftentimes I'm asked, we have national guidelines, why do we even need to do this work, is that going through this process allows for clinicians to get around the same table and come to consensus around how they want to deliver care. And there's more buy-in than just taking something off the shelf. So we'll look to national guidelines first, and then oftentimes we're doing projects where there's not great literature and evidence, so we do have to look at the primary literature. And then we also have the opportunity through the guideline development process to bring in local data. So we're able to look at OHSU's own data. And then, as I mentioned, we have that patient voice. So it's kind of the marrying of those different factors that lead to the development of clinical practice recommendations. And I think there's great value in that, but I think that the most valuable thing that this work really contributes is that translation piece. So we're really trying to design systems to support this, whether that be with EPIC enhancements like creating clinical calculators or making revisions to order sets and smart sets, or changes in documentation and flow sheet, all that's included. As I mentioned, we also talk about patient and provider education. And then sometimes we see that there's really a gap between what's recommended and what our resources are. So this is an opportunity to call that out and to bring that to administration and say, hey, we need more funding for medication-assisted treatment for our patients with opioid use disorder, et cetera. I just mentioned that because I've been living and breathing opioid guideline implementation since our EVP program manager who's leading our implementation efforts is now on a maternity leave. So I think one common criticism that I often hear of evidence-based practice is that it's really cookie-cutter medicine. It's taking away from clinicians the ability to practice the art of medicine. And I would really argue the opposite. So I think the art of medicine really lies in observation and being mindful of what's happening around you and what's happening with your patient. And I feel like what evidence-based practice does is it gives you the most complete set of information. And then it's really up to you as the provider to decide how care should be given to the patient sitting in front of you in the exam room. So I would argue that evidence-based guidelines enhance your ability to deliver medicine in an artful way while removing complexity. So these are guidelines that we have worked on over the last year and a half. We have a site-specific to OHSU guideline for cystic fibrosis it's a pain and anxiety management guideline for CF patients. And then the guidelines below that it's all work that's happens at the health system level. So we currently have guidelines for safe opioid prescribing for chronic non-end-of-life pain, as well as for supplemental feeding in healthy term neonates. These guidelines are now in the implementation phase. We just completed a guideline for colorectal cancer screening. I'm actually presenting it to the professional board this afternoon and hopeful that we'll have an approved guideline and be able to move forward with implementation this month. We've launched guidelines around heart failure and acute low back pain, and then are hopeful the next month to launch guidelines for pancreatitis and dialysis. We have a website. We're a little bit buried on the O2 site, but it's here, and all of our guidelines are available, as well as there's more information about how to request a guideline, more information kind of just about the guideline development process, and some of the other resources and tools that we provide. I just wanted to quickly walk through an example of our guideline development and implementation process and some of the outcomes that we've been able to see. So the first guideline that we developed at OHSU was for CF patients. It was a pain in managing their pain and anxiety. And that's a very targeted, narrow focus, and that was a little bit deliberate. We wanted to see how the process would work before we launched efforts on a larger scale. And there was also, I think, good reason for selecting this guideline for development. We have noticed over the last couple years an increased number of patients being admitted with cystic fibrosis. Also, those patients are receiving more opioids than in the past. Patients are also receiving messaging about opioids is highly, highly variable, huge variations in care that's being given. And then our data show that patients who are receiving opioids have longer length of stays, even when you're accounting or adjusting for disease severity. And they're also more likely to be readmitted. So running this kind of through our prioritization matrix, we had a highly engaged group of clinicians that wanted to tackle this. And yes, there was sponsorship. We felt like this could really improve quality and patient experience. We did expect to see a financial benefit because we were hopeful that we would see a decline in length of stay. There are some best practices that we could draw from, so we used the new guideline that came out from the CDC in 2016 that Roger Chow, essentially, he authored the systematic review to inform it on opioid prescribing. We felt like this could enhance provider wellness and satisfaction too. So we formed a guideline development team of over 20 clinicians from across OHSU. It was very multidisciplinary. We had representation from nursing, pulmonary, social work, hospital medicine, RT, pharmacy, quality management. We had residents participate, internal medicine. We had informatics at the table because we're realizing that's a hugely important part of what we're doing, especially as we're talking about implementation, and then it was supported by our team. So in terms of what we did for implementation, one of the big things is we revised the cystic fibrosis admission order set, removing the option for IV opioids, and then delineating different pain management options by pain severity. Currently, the previous order set listed the IV opioid options first. So that's what a provider would see first when they were going into order pain management meds. And then we did a lot of education, presented at grand rounds, we went to faculty meetings, we had meetings with nurses, physical therapists, RT, we developed posters and flyers and plastered them all over. We also communicated via newsletter and email. And then we sent a letter to all 242 known CF patients at OHSU, letting them know about changes that they could expect in their opioid prescribing to try to ease some of those difficult conversations that they would have with their providers. And we went through one PDSA cycle, and then we did a feedback and some focus groups, and made some revisions based on the feedback that we got from that. Our CF admission order set, the revisions went live in March of this last year. So here's our data. So our baseline period is January 2016 through February 17. And then you can see our 3-month data and our 6-month post-implementation data. And this is really hard to see, I'm sorry, but this is showing order set utilization. So we saw an almost 10% increase in order set utilization. It was already pretty high. It was at about 87%, and then it went up to 97% and then 96%, respectively. So this is looking at morphine milligram equivalents per day per patient. And we saw an average decrease after implementation of 10 morphine milligram equivalents per day. That wasn't statistically significant, but we were trending in the right direction. And then this is looking at length of stay. So after implementation, our length of stay went down by about half a day. Again, not statistically significant, but when we presented these findings to our content expert team, they felt like they were clinically meaningful and were excited about it. So this is showing inpatient length of stay by whether or not the patient received an opioid. And here you can see that for patients on opioids, they experience a length of stay reduction of 1.77 days in the 3-month data, and then 0.75 days from that in the 6-month period. So again, not statistically significant, but we're feeling encouraged that those measures are trending in the right direction. And I think that as we get more patients, I think the ends were pretty small. We'll hopefully see a statistically significant difference. But our clinicians on the content expert team, we're very encouraged by the data. So as I mentioned, we've often encountered times when our evidence doesn't match up with our resources. So with our CF guideline as well as our opioid prescribing guideline, we recommend non-opioid alternatives, including complementary and alternative medicine therapies like acupuncture, massage, but those are not readily available on the inpatient side. So one of the things we're doing is trying to address that gap. So we've looked at increasing access to non-opioid pain management for patients by determining what therapies and services are offered across OHSU, and then also exploring what services are covered by payers. And we're currently working on developing a business case that would allow for providers in the outpatient pain center who provide those services to come up to the inpatient floors and kind of be a designated resource so those services would be available to inpatients. So I think as we've done this over the last year and a half, we've learned a lot. I think some of the biggest opportunities and lessons we've learned are we need to include patients in the discussion. So our CF guideline, we did not have a patient representative. And there's a very active patient advisory group for CF, and they were extremely offended to not be included. So I think just highlights, the importance of getting that voice and capturing that as a part of the process. So for all of our subsequent guidelines, we now have a patient representative on our team. We're doing this across the health system, so we rely really heavily on technology. I'm horrible with technology, and so just kind of allowing the the appropriate amount of time to make sure that we're able to connect and kind of troubleshoot all of those issues was something that we discovered early on as well. And then engaging analytics and reporting early on. So I mentioned they're a huge part of our implementation work, but we've also started to include them as a part of guideline development too, because they could kind of speak to what's feasible in the system as we're thinking about recommendations and how they might apply here at OHSU. And then just making sure that we've got everybody captured. It's great to have everyone engaged early on as opposed to having to go back and apologize for not capturing a voice that was needed. So what's working, I think we've heard from clinicians, they really appreciate the interprofessional dynamic of the work. It's unusual to have a table where you've got multiple disciplines and specialties represented, and I think clinicians have really appreciated that. Free food is always a good thing, so we try to schedule our meetings over noon or in the morning and provide breakfast or lunch, and we always have cookies. The support from Andrew Hamilton, the medical librarian who's worked with our group, has been tremendously helpful. And I think providers, too, a lot of people have asked, like, how do you get doctors, especially, to do this work? And I think what they really appreciate is knowing that this is going to go somewhere. So they're not just getting together to put something on paper, but there's actually going to be systematic support for translating this work into workflow that will impact their patients. And that has gotten people really, really excited. And I think also just removing the burden of the search and summation of the literature from folks that are really busy has been appreciated by clinicians as well. So we do a pre and a post guideline engagement and alignment survey with every project that we do. And this is a quote from an attending physician. I think just really speaks to the fact that we've got wonderful, engaged clinicians here at OHSU who, when they feel like their work is actually going to translate into something meaningful at the patient bedside, get really excited and get highly motivated to participate. So there are a couple of other services that we offer through our evidence-based practice program. One is an evidence synthesis service. So if there are groups or committees within the hospital that want to use evidence to inform the development of a policy or a protocol, and it's a more targeted question, we can do a pretty rapid evidence brief with about a 2 to 3 week turnaround. And so here on the, I guess it would be your right, you'll see some of the evidence briefs that we've prepared over the last year, everything from appropriate interval for diabetic retinopathy screening to therapies for treating low libido in women to continuing buprenorphine in the perioperative period. And it's been exciting to see how this work has led to updates in policy and updates into how our electronic medical record is built as well. So that's a service that's available to anyone at OHSU. You can reach out to us either through email or you can submit a form on our website and request this service. And then we also do an annual evidence-based practice course, and the course is geared at interprofessional teams of clinicians. This last fall, we had 9 teams participate. Teams come to the course with a clinical topic in mind, and they essentially develop a guideline over 8 1.5-hour sessions. So they learn how to search the literature, how to critically analyze and appraise the evidence they're finding, and they use that to develop a guideline. So we had 9 projects come out of this year's course, and it was really fun. And we're able to use the course, or clinicians are able to use the course to get continuing education credits, as well as maintenance certification, Part 2 and 4 for physicians. And we'd anticipate that clinicians participating would also have the opportunity to get some really nice scholarly products and work out of their efforts too. That's just kind of a summary of an overview of our department and what we do. I certainly welcome any questions or thoughts, and would love to hear from you all. Yes.
Thank you so much for your talk. This is a very interesting topic, and I'm personally very enthusiastic about applying evidence-based medicine as an internist, like as part of the fellowship program. I still find that guidelines are not available typically at the point where they might be needed, where the question comes up, what's in the guideline?
Mm-hmm.
So, and like being informatics, the EHR would be kind of the go-to place. So I was wondering, what are your thoughts or your methods to, when you produce guidelines, to make them computer interpretable to some extent?
Yeah.
I know there are some like Arden syntax or glyph where theoretically guidelines should be translatable so that they can be actually automatically run against a certain data. But most guidelines that I could find online are in PDF format, where I have not even a chance of really using any NLP to work with them in a more automated way.
Yeah, that's a great question. I welcome, especially you all as informaticians, I'm going to mess that term up, your thoughts on that. But one of the things that we've done with implementation is to try to design the EHR in such a way that a doctor wouldn't have to necessarily go and look up the guideline. It would be integrated into their workflow. So whether that be through changes in order sets or smart sets or flow sheets, we do make all of our guidelines available within the actual order set, so you can link to the OHSU guidelines within the order set. And then also there's also a panel in EPIC under, I think, knowledge resources, where the guidelines are there within the EPIC system. But yeah, that's a good question, and we'll welcome others' thoughts and ideas on that.
Ilya Ivlev. Thank you for your presentation. So you said you involve patients also in guideline developments.
Mm-hmm.
Could you give one example maybe how patients' input affected your guidelines? What has changed? And
yeah.
You talked that physicians are satisfied with the process and the results. Did you ask patients if they're satisfied with the new care? Or, you know, like something like from patients? How do they see the results?
Yeah, so the cystic fibrosis guideline is one of the only guidelines that we've got data for right now. We're working on getting baseline data for both our opioid prescribing guideline and the supplemental feeding guideline. But that's a component of both those guidelines is, well, actually for CF2, is patient satisfaction with their care. We found that it's challenging to get that information because you're either creating a separate survey or you're using information that's gleaned from just kind of the general patient satisfaction survey that is sent out by OHSU. But I think that's going to be a really important piece, and it's definitely something that, I mean, we've listed it as a measure and something that we want to track and monitor. But would welcome ideas if you all have thoughts on kind of the best way to do that. We've been struggling with it a little bit to date. And then in terms of your first question about how the process was different or how we saw benefit from a patient expertise, with implementation with the opioid prescribing guideline, we've got two chronic pain patients that have been really helpful in helping us sort through content and information that's available to patients. So trying to figure out and identify what they really need and what kind of resources they want and where that should be housed. Their perspective's been really, really helpful to us, and we've certainly changed kind of our proposed plan for patient education based on their feedback. Yes?
Oh, great job. Can you talk about how talk about the how the governance of maintenance of the material updated literature review process is going to go as you scale up to more clinical questions? And also, have you been able to maximize the literature reviews that you've done in other ways to, do they fall hand in hand with requests from medical societies to do evidence syntheses, or is this just built from the institutional's priority as you specified on that one slide?
Yeah, that's a good question. So most of our guidelines are selected based on strategic organizational priorities, but that's not to say that we don't think that they'd have value outside of our organization. So a lot of the evidence briefs are now actually being turned into publications, and they're narrative reviews describing kind of the state of the evidence, and then also describing how we have used that here at OHSU to change policy and practice. In terms of the updating process, all of the guidelines are updated every 3 years, or we are monitoring the literature to see if there's any seminal studies that come out that would indicate that we need to make changes. We're also looking at regulatory requirements to see if there's any measures that would come out that would indicate that we need to pull the team back together. But in terms of the update, we look at the literature that's come out in the last 3 years. We'll pull the original content expert team back together and update the guideline as necessary. Yes?
Hey, Dave Dorr. How are you?
Hi.
So I enjoyed this talk. I actually have answers for this one, which is that Rick Schiffman came up with this guideline encoding method, I think Jim, he calls it. It's not well documented, so it's a little hard to find, but it's definitely worth looking at because it does allow you to sort of encode the guideline steps and then attach measures to them and then monitor that. And sort of you can see where things break down. I don't know if I'd wholly recommend it, but since you're interested, you should look into it. So actually my question is sort of broad, which is when you think about putting the guidelines out and then you're really trying to create behavior change, what would you change if you had a magic wand to make that easier to do, either in the EHR or through your educational efforts? Like, what would make it easier for you to sort of take what you come up with and put it implement it?
Yeah, that's a really good question. I think better ways to communicate, to get content and information out to a wide range of people would make a big difference. And then if our friends in IT could say yes to every proposed optimization, that would certainly make life a little bit easier too. But yeah, I think those are the two things. Is communication seems really hard when you're talking about this, especially for something like the opioid prescribing guideline that affects such a broad range of people. Strategies for that can be helpful.
Hi, Ben Orwell. I know I think I've asked you a little bit about this before, but what kind of, and I think you guys have some of this built into your guidelines, but how are you doing in terms of knowing whether people are following them?
Yeah. So some of the process measures for our guidelines include things like order set, utilization, but that doesn't always get at whether or not care is being delivered in an evidence-based manner. You could still be delivering evidence-based care, not be using an order set, but that's kind of a proxy measure that we have. And then I guess, too, just being able to monitor some of the other process measures that we're looking at. So was the prescription drug monitoring program checked before prescribing an opioid? For our supplemental feeding guideline, was the newborn weight loss tool used before ordering supplementation? Some of those kind of process measures give sort of an indication of whether or not a guideline is being followed. And then, Dr. Dorr, kind of to follow up, too, on your question and thinking about implementation, it would be so much easier if our health system and the reimbursement models aligned with some of the changes in systems of care that we're hopeful to implement. The fee-for-service model makes things challenging sometimes.
I really like the criteria that you have in place for kind of filtering out the requests that come in so that it's not just the loudest voice that's getting your services. 2 quick questions. Is there a fee for your service? And then what is the percentage of like requests that you're able to then follow through with and develop guidelines?
Yeah. There's not a fee. We're a free service. We're funded by the hospital to do this work, both for guidelines and the evidence synthesis service and the course. There's no fee for any of those services. So because we're still early, I would say most all of the requests that we've gotten, we've been able to commit to or at least put in the queue. Some of the work, we're also trying to figure out how we might be able to fast track the guideline development process. So if there are guidelines where topics where we know there's really good literature out there, how can we make this faster and streamline things a little bit? So we're looking at doing that with sickle cell disease, and I think our heart failure guideline may sort of follow kind of the same sort of process. We're getting to the point now where the demands are exceeding the capacity that we have, but to date we've been able to tackle most of the requests that we've received. Yes?
I think it's still on. So having worked on systematic reviews and a scoping review, and I'm sorry, you may have said this in the first few minutes and I was late, how do you do 2 or 3 weeks, look at the evidence and summarize it so quickly? There must be some strategy for streamlining.
Yeah, it's more like a rapid review sort of methodology. We're not doing formal meta-analyses and pooling.
And no dual review, probably.
We do a dual review. So we do a dual review of the abstracts as well as the quality assessment. But the questions really are more targeted and narrow and focused. And we will work with the clinicians to figure out what they care most about and try to figure out where we can limit our results that we need to go through. So it might be we focus just on trials or on systematic reviews, kind of depending on what the question is and the volume of the literature.
Any other questions? For those of you who are in fellowship programs or who are students, what I'm interested in is how much you think what you're learning here applies to this and what do we need to do differently. So this is part of our thinking about how improvement science and informatics overlaps. If anybody wants to venture into that, otherwise we'll wrap things up, because I don't have much of a voice. Well, if you have ideas, you know where I am. I think most of you do. I'm upstairs on the 5th floor. And you know other people around here who are thinking about this, Karen and Vishnu and David. All right, well, thank you all for coming today. And if you have ideas of other related topics or related people you'd like to hear from, let us know too.
Yeah, here's my email and our website, but certainly would welcome an opportunity to connect with you all around this as well and hear what you're doing and how we might be able to support each other. Thanks for having me.
I'll meet with Kevin and try to come up with a plan for that project. He's discovered in the weeks.